Good evening, everyone. I'm telling good evening because it's almost the night to Sri Lanka, but I can also see that some of the members from other countries have joined. But more than that, Anna is here, Anna's from Norway. So again, I think it's almost good evening to you as well, Anna. It's almost, I think, 4:30 p.m. from your time. So, dear colleagues, welcome to this very important webinar by the Values Committee of the College of General Practitioners of Sri Lanka. Our topic is Family Medicine in a Digital World, Keeping Our Values Alive. And we have two eminent speakers with us. Dr. Anna Stavdal, who is also an associate professor in University of Oslo, Family Medicine Department, and a family doctor or general practitioner from Norway. And more than that, I have worked closely with her as an executive member of WONCA when she was the WONCA president from 2021 to 2023. And importantly, she is the lead of the core values project of WONCA, which we started about 3 years back. And I will talk a few words about that, I'm sure. We also have Professor Gominda Ponnamperuma, probably is not very new to many of you Sri Lankans colleagues. Professor Gominda Ponnamperuma is a professor in medical education in Faculty of Medicine, University of Colombo. And he is also very much connected to the college. Now he's holding the co-chair position of the Curriculum Review and Development Committee of the college, because we are in the process of reviewing and revising the curriculum of the MCGP program. I'm Dr. Sankar Andanikumara. I'm the honorary secretary of the college and your moderator today. With that, I would like to start, but just to tell a word about the Values Committee. Values Committee is not a new committee in the college. It has been there from the beginning or later, soon after the beginning of the college. College is also almost like 50 years old, more than 50 years old. And Values Committee have been dormant for some time, but then with the WONCA Core Values project, we also the project inspired us. We were also inspired by the project to revive the Values Committee. So with that, here we are with the first webinar. Our Values Committee's chair is also the college's president, showing the commitment of the presidents to the values, core values of family medicine and general practice. I think Dr. Pushpa is here with us, madam. I know she was amidst another event, official event, but she also promised me to join today. Okay, let me see whether. Okay, if not, I will.
Yeah, Sankar.
Is she there, Dr. Pushpa? Is she there?
No, I
can't see her. Yeah, I will give her a chance later. She wanted to speak a few words, but anyway, so straight to the topic. The first topic, I'm inviting Dr. Anna Stavdal to talk about adapting the family medicine value base in the digitalization era. Family medicine values are always important, and we felt the importance of values in the recent disaster too. I think Anna will also talk about that. And Madam President is there. Sorry for disturbing. Dr. Pushpa, over to you to speak a few words before we start the webinar.
Yeah. Thank you for joining. Good evening, everyone. Thank you for joining. So we have revived the Values Committee after about 8 years. So we have, before that, the Values Committee in the college had done a lot of work. They have developed 2 publications and some other guidelines also. So this year we are trying to review and revive those publications. So, I mean, I don't take much time. Sanka, I will hand over to you. Thank you.
Thank you very much, madam, for joining amidst your busy schedule today. So thanks for that. Thanks for those few words. And straight to you, Anna, to talk about adapting the family medicine value base in the digitalization era. Thank you.
Thank you very much, Sanka. I think I'd like to share my screen. Yes, right. So now I'll do that. One participant can share at a time. I don't think it's, I'm not, can you give me, can you allow me to share screen?
Yeah, anyone can share, Anna.
Yeah, but it doesn't, yeah, there we are. Very well. Now you can see my screen, right? Good afternoon and good evening from Norway. Thank you for the invitation. Sri Lanka is close to my heart, not only because you are nice people, but because your country and your region are both in need of primary care. So it's very meaningful for me to be in dialogue with you. Thank you, Sanka, for carrying the flag, so to say, for the Core Values Project, the Global Core Values Project. You are implementing the process way we work in your context. So thank you very much. And here are some questions from my context, very different from yours, from my practice, also from a visit from a Japanese colleague I just waved goodbye to yesterday. I know that your country is in a precarious situation right now, and I'm with you in that. As I'm speaking to and with you, I need to, as I don't usually list my credentials, I'm a fellow of your college actually, and then I had to add the Indian college as well and my WONCA fellowship, but Sanka has introduced me well enough. So what I'll do now, I will, as I said, I'll try and feel my way in the silent dialogue with you, or you are silent and I'm speaking. Starting with just a short recap to give background. What are we talking about? We're talking about the importance of primary health care, that family doctors are essential to utilize the potential of the primary care team. We are working for a family doctor for every family, and how can we justify that? We know our foundation. We provide personal, continuous, and comprehensive care delivered in the community. And here you see from Norway, from Guatemala, from Indonesia, and from India. You know this, of course. We are not alone to speak about values. This is already from the Center for Evidence-Based Medicine already 6 years ago, just stating, as you see here, value-based healthcare is the equitable, sustainable, and transparent use of the available resources to achieve better health outcomes and experiences for every person. And this goes across, of course, the whole medical community. Now we'll see. Yeah. So we are sort of committed to in up-to-date decision making, must consider values as well as evidence. That's a strong statement and a good basis to stand on for our conversation tonight. I like this quote from let's call him a hippie philosopher from the 70s. Nothing save change itself can last. So what we who are based in primary care, we experience the changes in our context, in the society, how it impacts healthcare first, because we are closest to the population. So what characterizes our time now? And I will get to the digitalization, of course. And these are global trends. They manifest differently in different socioeconomic contexts. But I think we share this, even if Sri Lanka and Norway are very different in many aspects, we share these trends. So we can see a synergy effect of market mechanisms, consumerism, commercialization, and underfinancing of primary care. We also see within the medical field, as we see in many other fields, specialization and fragmentation, and the complexity of system and processes are increasing. We can see also the trend to medicalize normal phenomena, and we also see a medicalization of everyday language, and I will get back to that. So, in a way, the sum here is that expectations to healthcare exceed realities, what we actually can deliver, and maybe what we want to deliver. And here comes my how I want to fuel the fire, to say that digitalization is fueling this development. And then you can think, oh, well, this old-fashioned woman sitting in Norway, what does she mean? What I mean is that the development as it is now leaves us in a position which you can use the English expression between a rock and a hard place, and that is not a good place to be. First of all, the positives are obvious of digitalization also of healthcare. We know the electronic patient records, electronic prescriptions, electronic communication between levels of the healthcare system itself, access to healthcare in remote areas where people cannot access physical health providers, and of course also in monitoring and management of chronic disease. A lot of positives, so don't misunderstand me. My intention here is to try and balance the discussion, because what we also know, I just read in a paper today about the AI bubble, which is now growing over its limits, a lot of investment and very little thinking about what it does to us, not only in healthcare, but at large. Okay, what would I say are potential negative effects, negative side effects of the use of algorithms? Because what I mentioned on the positive side are mainly digitalization, digital tools to manage, to communicate, to document, and to make the communication easier and faster. Some potential negative side effects of algorithms are listed here. If we look at self-evaluation forms, do I have a depression? Do I have anxiety? Do I have ADHD? Do I have irritable bowel syndrome? There are lots of online self-evaluation forms online. Psychometric tools used in diagnosing by the doctor or other health providers as well. Risk calculators. All of those algorithms address issues with a confirmation bias. That is my statement. We can discuss. So, in a way, this contributes to an expectation crisis already mentioned in the population, expectation frustration, because if it's said online, if I find this form and that is quality assessed and I score in this or this that way, well, what do I do? And what are the expectations? If the doctor says, well, I'm not sure I agree with your assessment there, is there also a way to give people on not so good premises a way to support the survival of the fittest? And here meant those who are the best to orient themselves online and in these algorithms also will be first in line to have this, what they find there as a ticket to further investigation and treatment. So that might be an equity issue. What it most definitely can contribute to is overdiagnosing, overtreatment, and maybe also medical mistreatment if we treat people on wrongly basis. All right. So we need to speak about power, because to the subtle yet potent ramifications of the intrinsically asymmetric balance of power in the patient-doctor relationship and how algorithms can strengthen that. While digitalization may seem at first to address that imbalance by facilitating access to healthcare, it may also intensify inequity. Those with limited digital literacy or equipment become marginalized from care, thus reinforcing existing social divides. The specter of this two-tiered system looms large, with inexpensive algorithmic services being offered to the disadvantaged, while human-centered relational care is available only to those who can afford it. We are at risk of reconceptualizing accessibility as if referring to a marketing device rather than a marker of equity enabling solidarity. This is something we need to discuss. Put upside down, look at it from different perspective, so we don't lose the positive impact this can give us, but that we don't leave people behind who we should not leave behind on these premises. So social media, I think I'll maybe go to the next picture here, further complicates such dilemmas. It may democratize information and empower patients to participate more actively in their own care. However, it may also blur the boundaries between evidence-based dialogue and market-driven responsiveness to consumer demands. So the promise of continuity of care, which I mentioned to start with, warps into an indiscriminate validation of all patient preferences, perhaps at the expense of the physician's clinical judgment. Patients seem then to transform into clients and physicians into service providers. And we must remember that the algorithms operating social media platforms are not designed to increase medical relevance, but to maximize user engagement. So they are inherently context blind. The final pivotal issue here is language. It is not only a diagnostic tool, but also a moral one, as it shapes how we perceive ourselves and others in the face of vulnerability. We are vulnerable when we go to the doctor. We are vulnerable when we feel that our health, when we experience ill health. So due in part to digitalization and social media, medical terminology now permeates everyday speech. Using biomedical jargon to discuss the daily life impact of a patient's illness obstructs and patient's illness and obstructs any burgeoning awareness of their existential reality. How do they experience the situation? Our aim is to assist their access to the inner experience of the meaning their suffering holds for them. To me, this is a value. And that is where our deepest humanity resides, the magma, so to say, of our being. So, unless these trends are counteracted by a renewed commitment to context and personhood, we may unwittingly participate in eroding the very foundation of medical professionalism and our professionalism as family doctors. So, what is missing in the digital health tools? That's the context. And I will speak a little bit about what that might mean in our clinical settings. But I will just show this quote to you from the Special Rapporteur on the Right to Health of the United Nations Human Rights Council. She says, reductive biomedical approaches that do not adequately address context and relationships can no longer be considered compliant with the right to health. Strong words. They appeal to me, as you understand. Give me a second here now. I'll just find, I have made some notes, so I just don't get astray here. In the textbook, known to many of you, Textbook of Family Medicine by Ian McWhinney, he formulated foundational principles for general practice. One of these underscores that we cannot fully grasp many of the conditions encountered in primary care unless we examine them within the personal, familial, and social framework. That is, within their context. The metaphor McWhinney used for contextual understanding remains apt. A single piece of a puzzle may seem meaningless until placed within the larger picture, at which point its role immediately becomes clear. We rarely, if ever, notice the pledge woven into the etymology of that Greek term diagnosis. Dia meaning complete, gnosis meaning knowledge. So thus to qualify as complete, a diagnosis must be based not only on a thorough understanding of an illness' biological mechanisms, but also as an inquiry into the wide and narrow context of the specific human being who contracts that illness. Since McWhinney wrote his textbook, we have gathered evidence for the importance of context to understand illness. Let me mention a couple of them. In 1998, Felletti and companions published this study, The Adverse Childhood Experience. I will not go into details, but for those of you who are not familiar with it, I invite you to look at the conclusion here. We found a strong graded relationship between the breadth of exposure to abuse or household dysfunction during childhood and multiple risk factors for several at the leading causes of deaths in adults. I think we've had a common understanding that the psychological impact of abuse and dysfunctional families in childhood, that the psychological impact we have sort of had confirmed, and we have accepted that. But this goes, what this study shows, it goes also for somatic disease. And as I say here very strongly in the conclusion, leading causes of death in adults. So it should be of great interest for us. This landmark study provided quantitative evidence for what family physicians had long observed. Life experiences leave biological traces. Scholars such as Kirkeng, Getz, and Ulvestad, Norwegian colleagues, have advanced an integrity framework linking human biology with biography. Human beings, reflective, meaning-seeking, and relational organisms, are also physiologically malleable. Stress, neglect, and trauma can disrupt our neurobiological regulation, but experiences of trust, recognition, and belonging can promote resilience and healing. Their work underscores that contextual adaptation is biologically grounded. That is the link I want us to focus on. So there are more evidence, but in respect of time, I will go on. What we need to ask ourselves, what are the barriers to implement this evidence? And we must ask, might digitalization be a potential barrier? I'm not saying that is all it is, but we need to be proactive to ask that question. So to do that, what to do? Reflect on it in the digital era, not to lose sight of the basic insights and to fully integrate our principles in everyday practice in modern times, to adapt to constant change. We are living forward. We're not living backwards. We need all the time to nourish our commitment to empathy. We have to understand our own context, and we need to review recruitment to medical education and the curricula we offer. I'll give you an example. We are doing this from different angles, contributing to the collective effort which is needed. Here is Florian Ziegler, a German family doctor, who is running the family medicine golden nuggets. You can make a submission and have his monthly newsletter. He says he wants to provide. This is an example. In my country and many other countries, it has been discussed whether paracetamol in pregnancy can be a factor for development of autism in the child. And he goes into the knowledge base from a family medicine perspective and shares it online all the time, also with the family medicine value base in mind. Already mentioned the WONCA Core Values Project. That's another arena. It was, as Sanka mentioned, it is actually soon 3 years since we started it. I was still your president of WONCA when that happened. In a newsletter, I invited people to write to me. What matters to you with the core values? And in Sydney, same year at the WONCA World Conference, we had a kickoff meeting, and together with Felicity Goodyear-Smith from, I'll see if I got that slide here. No, I don't. So let me go back here. And I will, two good colleagues, my Icelandic colleague Johan Sigurdsson, retired professor in Iceland, and Felicity Goodyear-Smith, not yet retired. I think she will she will work forever. Professor of family medicine in New Zealand. We are the steering group, and we found 7 regional leaders, of which Sanka is one from the South Asia region, and we asked them to collect people around them, to establish working groups, local working groups, regional working groups. And the goal is to develop and maintain a shared vocabulary of our discipline, enabling us to reach out to colleagues throughout the world, enriched rather than hindered by our differences. And to achieve that, we need to identify what these differences are. And this webinar is maybe a way to unpack that a little bit, to better understand ourselves and each other. So, and this is important for all WONCA activities, and I would say all for all member organizations in WONCA, including the Sri Lankan College, for education and training, research, professional development, and not least advocacy. The outcome of the first phase was a book, regional chapters and 3 chapters written by and in addition to that, 3 chapters written by the steering group, Johan, Felicity, and myself, and it was launched in Lisbon. Very fun, huge launch. Fun for us, at least. And all the books were sold out before at the stand was sold out before the book launch. But it's available online if you want to buy it, of course. Very welcome to do that. Here is the South Asian group main members, and we also had a symposium in Lisbon where we presented the book and what we're doing, and also how we did it. Because, and here comes the main point, this is a bottom-up process. It's not a top-down process. For family doctors to understand what matters to them when it comes to values and principles in family medicine, and to be able to implement it, it is absolutely crucial to have won it for themselves, for ourselves. And to do that, we need to reflect and to do that together. The questions we want to brainstorm in phase 2, which we just started in Lisbon. We had our first online meeting 2 days ago. We need to map what are physicians who provide generalist care called in different contexts. We have primary care doctors, family doctors, GPs, lot of terminology. How are they trained? The different versions of this, and how are training schemes in accordance or not with our core values and principles, and what is our colleagues' work context? Are they hospital-based or community-based doctors? This project also meets the work to implement the Sustainable Development Goals, and not only for goal number 3, good health and well-being. It is, I would say, not to be too high and mighty here, almost all the goals, and at least the 3 you see here on the screen. And I know also climate action is high on the agenda for many of you. So here is what we're trying to do. We're coming with our book and our project, meeting the WHO community and the whole global policy dialogue community to build a better understanding of how we can reach the goal, how family medicine and primary care are prerequisites to reach it, but also to do that and to be convincing, we need to understand what we are based on, what we stand on. And in the era of digitalization, to circle back to that, our reflection work is of very Very, very high importance. Here comes, I can see, here's a quote in Norwegian, so disregard that, but compassion is known to you. Compassion is a value in the era we're living in, and we could list a lot of threats I think we share. I have given you my perspective on what is challenging for healthcare and family medicine nowadays. Whatever we mean about digitalization, use of digital tools, if you find it meaningful or not. I see you coming back now, Sanka, and I will end in a minute. We need to nurture our ability to compassion. As Mona, our East Mediterranean lead, showed us when she spoke to us, she quoted Rafi Tomasian, the family medicine resident, who said, "I will become a family medicine specialist soon, as it is part of my humanitarian mission to care for those in most need." So here is my final greeting to you with one of my practice assistants on the picture here, and a patient and a newborn baby. When people are cared for and are enabled to care for each other, global stability increases. Thank you very much for listening. I'm ready to discuss.
Thank you, Anna, for that thought-provoking talk. And in one of the last slides where you talked about the project inside the South Asia, you saw that probably one of the emerging core values was digital health. And at a point, you told that we need to adapt to the constant change, and digitalization is inevitable. And I think we have to, as you told, we have to take it as an opportunity rather than a threat or a challenge. So thank you. We will move to the next speaker, and then we will go into the discussion. Professor Gominda Ponnamperuma is with us. He's a medical educationist, and we'll be talking about values in GP education. Over to you, sir.
Thank you very much. I hope you can see my slides and you can hear me. Let me. I hope you can see my slides. Can.
Yes, you can see.
Yeah. So I am actually, the topic that was given to me is values in GP education, but I'll be talking more about medical education, of course, which is not considered something outside GP education, because GP education also belongs to the wider domain of medical education. So my talk will be very general, because as you know, I'm not a practicing general practitioner, but I think what I say should be able to be contextualized into into GP education as well, from what I know by working with you for some time now. So what are values? This is a psychological model. Psychologists are the people who propose this. So beliefs, values, attitudes, and behavior. What they say is beliefs are the primary underlying thoughts that forms our values. And the values can be translated into attitudes, and some of the attitudes may influence our behavior. So, Sanka, I am not able to, whatever, all right, okay, fine. So beliefs are the things that sit very much inside us, which will influence our values, attitudes, and behavior. So if I give you an example from general practice, so if we have a belief that patients do not know, unfortunately, this is a negative example. So patients know nothing. Then we would value a consultation model like patriarchal model, a doctor-centered model, rather than a, a, a patient-centered model. Then the attitude would be more specific. So attitudes are more specific and behaviors are even more specific. So attitude would be that such a GP will have a positive attitude towards silent patients. Patients who will not ask questions or question what you say, they will be meekly giving in to whatever you say. And probably the behavior would be such a GP will be irritated when a patient asks a question. Don't you understand? Have I not been explicit? Or you are not here to question me? That's sort of an attitude. So what we see is this, but what is underlying all that is this. And as I said, this is very much a psychological model. As you can see, the observability of all this will go up as we go down. That is, only perhaps the most observable one would be the behavior. Attitudes may be observable a little bit, values even less, beliefs we may now never come to terms with from as an outside. But within ourselves, of course, we can introspect our beliefs. We can challenge our beliefs. We can analyze our beliefs. That is only for us. So we are talking about values, but we in medical education have more terms than the psychologists. So here are some of them. What are virtues? Virtues are called good qualities, traits, characteristics based on beliefs. Again, the underlying phenomenon would be a belief. So I have listed some of them: integrity, honesty, altruism, compassion. Then we have attributes. They are not only, of course, all these have overlaps and their boundaries are very blurred. They are not in watertight compartments. So attributes can be, unlike virtues, which are always good, attributes can be good or bad. Basically, they are dispositions, or the outlook. They will determine the outlook of a professional. So professionalism, physical strength, empathy, patience, all those can be on a spectrum. So they are usually called attributes. Then we have competencies. That's an ability which is often a combination of knowledge, skills, and attitudes to varying degrees. And here are some of them: communication, leadership, teamwork, lifelong learning, cognitive skills, and so on. So at least to have some idea of these things would help us to navigate the literature, at least, because literature is full of these words. Sometimes they are used interchangeably, which I am not critical of at all, as long as we know what we are talking about. So values, if you consider that inner circle within beliefs are internal. They are also not external unless we are explicitly showing it up. They are personal, actually intrapersonal rather than interpersonal. Multifactorial, formation of a value may have a genetic component, may have a developmental component, may have an environmental component, and so on. You can't really specifically say this is due to this. It's a contribution of many factors that may form our values, and this experiential component may be also quite high in our values. They are deeply and firmly held, but changeable, but not easy. They are observable only if turned into behavior. And my earlier slide showed a behavior, being irritable when a patient asks a question. That's what we see, but what we see is only the tip of the iceberg. They are being controlled by the values and the beliefs that physician holds. I had the chance to look at what Anna also mentioned about the WONCA core values book. So all these are your values, perhaps not only yours, any physician's values. And I can perfectly relate it to them. But then the question is, what are we going to do with them? It's one thing to recognize them. I think that's the first step. And I think I should commend you for recognizing them. But we in education will ask them, how are we going to promote these? Can they be taught? Can they be learned? Can they be assessed? An older document of yours, I think you started, that is, your college had started this much earlier than even WONCA, and I found this in this book: loyalty, advocacy, decency, respect, compassion, empathy, integrity, competence, and so on. So what are we going to do with these? From an educationist point of view, my questions then would be, how are we going to teach them? How are we going to see whether they learn it, and how is there a way of monitoring progress, and how to assess? These are difficult questions. These are not at all straightforward questions like a technical skill. For example, venipuncture. That's easy to teach because it can be, the steps can be very discreetly documented, and you can observe and see whether now a person is doing it well or not. But unfortunately, these are not like those skills. These are very internal. They are hardly seen, and therefore it's not easy. But having said that, being not easy is not an excuse not to explore and not to promote them. So therefore, we need these things need to find their way into our curricula, into our teaching learning, and into our assessment. So I have asked the question how to teach, but within brackets is what really matters, not teaching or learning, because I don't think teaching and learning they are appropriate words. Probably imbibing or internalizing is more appropriate for values. So these are some of the methods that I have seen people use: case-based and problem-based learning. If you analyze a case, then you can get to the bottom of that behavior of that physician, and what would have influenced, what sort of values, beliefs, attitudes would have influenced that type of behavior. So case-based learning is great. Small group discussions, just to discuss an event and see how that sort of an event took place, what sort of attitudes, values, and beliefs would have influenced such an event. Debates are good, because always these are not clear-cut. There can be advantages, disadvantages, pros and cons, and all that can be debated. These are very strong ways of internalizing values: films, stories, poems, artwork, dramas, etc. Humanities, in other words, because they send a strong message to a person, even with a different sort of a value, and will sensitize the person to adopt such values. Reflective practice is always good. You can reflect on your behavior, you can reflect on others' behavior, and see what sort of thoughts would have influenced that behavior. Role modeling, seeing somebody acting in a certain way in a certain situation, in a certain context, followed by some open discussions, why was that so, would also lead to internalizing certain values. Feedback, debriefing on performance would be also a way of internalizing them. So they are not at all, it's not a lecture on values, or it's not a lecture on empathy that will really promote internalizing. A lecture on values or on empathy or on altruism or compassion would be okay to introduce the concept. If you think that concept is not even heard by certain people, surely that will work. But thereafter, these would be the ones that really internalize the values that we want our learners to internalize in the way that we want. Very briefly, how to assess. Again, you can't assess. That's the bottom line, is that you can't assess, but probably surrogates of values can be assessed. How? Written questions can, to an extent, surface certain values if that writing is based on a case. Again, a case-based type of question. Then, in simulated situations, how people behave, like an OSCE, for example, may be useful to at least to get a indirect measure of a certain a person's value or attitude or belief that that person has. Assessment of actual behavior is much better, the workplace-based assessments, especially if the person who performs that does not know that he is being performed. So workplace-based assessment with CCTV footage would be ideal, because that's where the real values, real attitudes will surface, will come out. If you assess portfolios, reflective diaries, there will be some indications of the values that that person holds. All these are external. The two that I'm talking now, I think Anna also mentioned one of them, is more personal way of assessment, and I consider them as true assessments, because then you're honest to yourself. You're not showing anybody that you have this value or that value. So self-assessment, introspection, just to look at yourself, to have some reflexivity rather than reflection, which if you document, you are showing others also. But without others, just thinking what happened, what are my values, did those influence this behavior? And how did it influence what I did, and what are the repercussions, positives and negatives of what I did? I think that will help us to get to the bottom of our thoughts and values. The next one is, I think, is what also Anna also mentioned, self-administered questionnaire scales, which I think and I mentioned in a subtle way as psychometrics. This is not to diagnose, though. This is to diagnose yourself. So you are not giving this questionnaire to somebody else, a researcher, but you are doing it for your benefit, to see what are your values. Such use of this would be quite useful, at least to throw some light, but they are not perfect. But at least it will give us something to reflect on. So these are some of the ways that we can use assessment to sort of analyze our values, and at least to know these are our values. Finally, some take homes, which are not, this is not really the summary, but some take homes. Values are fundamental to any profession, as they shape the conduct of its members. For people's professions such as medicine, it is even more important that the practitioners have the right values. Values are usually shaped by beliefs, and hence are personal, interpersonal, intrapersonal, multifactorial, and not easily recognizable or changeable. However, they can be changed. And so we in education, this is my critique, do not really address values that much. But we are more interested in shaping the learner's behavior, because that's what we can do in the little time that we have. However, that's not an excuse. Right values will always guide the behavior of a true professional. So we need to address them with a more concerted effort and more purposefully. Thank you.
Thank you.
Over to you, Sanka.
Sorry.
Yeah.
Thank you, Professor Gominda, for that interesting thoughts. When you were telling that values are more internal and personal, I was realizing that we as family doctors try to share the values of our discipline. I mean, we are trying to share those discipline-related values as internal values, personal values to us. And also, when you told that it's multifactorial and it has some genetic component, the development and environmental component, and also they are sort of deep and firm, but also could be changeable. I was thinking the importance of training and education at a point, how we could, change people probably as early as possible. I don't know whether it should be like from the family themselves, from the small age, but then of school and then medical school, and when it comes to the postgraduate program as well, it's changeable. That hit me well. So thank you. Do we have any questions? Let me see. Not at the moment. I have a question from Professor Gominda first. As a medical educationist, your view, your talk was from the medical educationist lens. What do you think about, I'm just relating to Anna's talk.
Yeah.
What are the challenges you have in this digital era when it comes to medical education? Or so in general, GP education is a part of that. What are the challenges you face?
I
Thank you for
think that's a good question. Sorry, Anna,
Okay.
do you want to have the first go? I can, yeah, sure. Go
I
ahead.
would absolutely like to tell you how it resonates to me, what you just delivered, the presentation you delivered, and it goes exactly and directly to the question you asked, Sanka. I think digitalization sort of fuels development, which I'm worried about. And that is, you mentioned, Gominda, you mentioned the importance of introspection and self-assessment. And related to values, that is actually an underlying motivation for me to start the whole project, because when we are reflecting on these issues, something happens also inside us. And what I think Sanka is missing in our education is introspection, focus on how we are as physicians impacted by our own context, our own upbringing, the values we have been given or not, and how we, in our context, can be a good mirror also for the patient. So I think that is lacking in medical education as such. And with digitalization, we are at risk of really losing that, because everything will happen online or on the computer. What we do have a methodology which is implemented in some countries, like my own. Not to say that's the ideal country, but at least we're doing this. It is obligatory to contribute in Balint groups, in groups, colleague-based specialization, and also for recertification for lifelong learning. I think it's very variable to what extent we actually do what we should do in those groups, because it means you need trust on a very deep level to, for example, volunteer how you don't like a certain group of patients, for example. If you have problems with dealing with health issues which are contentious maybe to your own values, religion, what do I know? The gender issue here. And so but there is a potential to do so. And I think in medical education, that is what we really should focus on. I will stop now. It became a long answer. Another thing I didn't mention in my presentation, but which I'm preoccupied with, is the way we recruit people to medical education. Is it based only on good marks? I mean, what about the rest? The ability to do what I just said, to reflect on your own context and who you are. So I usually say we need knowledge about medicine, knowledge about knowledge about the system, and knowledge about ourselves to be good doctors. Thank you very much for your presentation, Gominda. And may I now, Sanka, make an apology for saying that Florian Ziegler is German, whereas he is Austrian. For a Norwegian, it's almost the same thing, and that is, of course, not good to say, but I don't like when people say, yes, you're from Sweden, aren't you? No, not at all. I'm Norwegian. So sorry for that to Florian, and I will not say that again, Sanka.
No, sorry, because I would have told the same yesterday. Yeah, sorry for that. I would have reminded you yesterday. Sorry.
Thank you.
Over to you, Prof. Gominda.
I think I absolutely agree with Anna. I think what she said about selection or admission is core to it all. I mean, that's the best way a profession can uphold the values that it wants. Or maybe may not be the best, but the most the most fundamental, because that's where the gate is. That's where the gate is, and you open the gate only to the people that you want to be part of the profession. So that's one of the key ways to handle this. But Sanka, your question about digitalization makes values even more important rather than less important. Because in education, you asked me what are the problems with digitalization. The commonest problem we all know is that now assignments are not really assignments, they are AI generated assignments. So that is part of values. If you can be satisfied for yourself with an AI generated assignment or an AI generated set of slides, then who are you? Who are you? I mean, if somebody can ask that question, then, and if everybody can ask that question, then that problem is solved, but unfortunately, it's not solved. So values are even more important now than in the past.
Thank you. I would just acknowledge, as Anna mentioned about the core values project and the South Asia team, we have the extended team member here, Professor Shamali Samarwag, who is also a medical is a GP educationist, so I mean one of the academic from the college, which is also here. So we have our team around, and not only you and me. So any questions from the audience? I know it's not subject matter, uh, but I think a lot of points to ponder and think to ourselves. I think both presentations gave those sort of insights and questions to ask from ourselves and about our profession. Anything else from you, Anna? Probably we have of course we have almost
There's one
past 1 hour.
question, Sanka. I don't know whether
Yes,
it was
please.
in the
Yes,
chat
go ahead.
box from Suraj.
Oh,
Value
sorry,
of maintaining confidentiality.
lovely. Yes,
Of
sorry, I didn't see that. The question is value of maintaining confidentiality of doctor-patient interaction will be a challenge in digitalization environment. How do you ensure values, or I mean, ensure this? Anna, would you like to go first?
I think we have together, Gominda and I have already reflected on that. The importance. This is an internal thing which has to go on in one and each of us. And of course, we are under pressure with all, like we're discussing our teenagers and online and social media, etc., how they are affected. We are affected all the time as well. So we need to work even harder with our own awareness of our own values and how they impact the choices we make. When I now have the floor, I just also want to congratulate you on this number of participants on a Saturday late afternoon for you. That is impressive. And I don't think, if there are no questions, just like you said, Sanka, this will hopefully be useful to reflect on. I mean, this is not a quick fix, instant thing. We need to let it sink in, and next time we meet, we'll have more discussions. So I'm grateful for again for the invitation, for listening to Gominda, and for the work you're doing in your country and your region. Thank you very, very much.
Thank you, Anna. Just as you told us, I think we all are thinking to ourselves and reflecting on our values. So I don't think that we have any questions rather than asking questions from ourselves here. And probably you can discuss this after some brainstorming. So thank you very much to both of you, Dr. Anna Stavdal, WONCA past president, and a GP from Norway, a beautiful country. I loved your clinic. I loved your country and how the people were. And also to Professor Gominda Ponnamperuma, one part of the college as well, even though he's a medical education. So he has much understanding about general practice and the college. So thank you for agreeing to attend and deliver these presentations. And letting us to think more into ourselves and our values. Thank you, colleagues, for attending in numbers to this important webinar about our values. I actually did not expect this number because it is not mere subject matter, which is like, either. So this is a very good sign that we are thinking of our values as well. I'm very happy. So thank you very much. And let's meet another webinar, and stay tuned with the college's activities. And this webinar will be available on college YouTube soon. And also about the CPD certificate, it will be sent to you soon. Getting updated and continuous medical education is also a value. So we have not forgotten that. So thank you, colleagues. Have a pleasant
Thank you very
evening.
much,
Good
Sankar.
night.
Let me thank also. Thank you very much. Thank you very much. And it was a pleasure listening to you and discussing this important topic. Thank you.
Thank you all. Have a good night.
Have a good night, all of you.
Good night, everyone.
Good night.